Hi, my name is Dr. Sumiko Stein and my co-author is Dr. Gregory Brennan. We are at Medical City Arlington in Arlington, Texas. I am here to present a case on refractory diabetic gastroparesis treated with impedance planimetry system. Gastroparesis is a debilitating disease characterized by delayed gastric emptying. The suggested pathophysiology includes sympathetic vagal neuropathy, occasional interstitial cell abnormalities, and other causes. Pyloric dysfunction is increasingly recognized as an important factor in the pathophys of gastroparesis. A novel endoscopic therapy has recently been described using the impedance planimetry system with possible implications for treating pyloric dysfunction associated with gastroparesis. We present a case of a 34-year-old man with a past medical history of type 2 diabetes who presented with acute abdominal pain, nausea, and vomiting. Vitals were remarkable for a heart rate of 110, PE was unremarkable, CT abdomen and pelvis showed moderate stool in the colon. Labs were significant for a blood glucose of 490 and an anion gap of 19. A diagnosis of hyperglycemic hyperosmolar syndrome was made. The patient was started on the appropriate treatment. However, he continued to have nausea and vomiting and was unable to tolerate any oral intake. A clinical diagnosis of diabetic gastroparesis was made. He was started on prokinetics, but his symptoms still did not improve. Because of refractory treatment, the decision was made to proceed with upper endoscopy with impedance planimetry system. The catheter was placed side by side the endoscope and advanced past the pylorus. Proper balloon placement was verified by an hourglass shape of the balloon displayed on the monitor. If you look at figure 1A, you can see the monitor that displays real-time data during the procedure. B has a measurement catheter designed for this system that has an integrated pressure sensor for balloon pressure measurement. Measurements were obtained at the cross-sectional area of the pylorus at various balloon volumes starting at 30 milliliters. The balloon was then inflated stepwise at 5 ml intervals and measurements were obtained. The initial pylorus diameter was measured to be 13.7 millimeters. The pylorus was dilated up to the target diameter of 25 millimeters. The patient tolerated the procedure well without any immediate complication. His symptoms resolved and he was able to tolerate a regular diet. Figure 2 shows images from a study with citation below. A shows the pylorus before dilation, while F shows the pylorus after dilation. B shows the catheter with the balloon in the pylorus at a volume of 30 milliliters. Figure 3 shows sample displays of the recordings during the procedure. This image shows the pylorus at 40 milliliter balloon volume distension. The bottom of the image shows a pressure of 22.2 millimeters of mercury, and the right side shows a pylorus diameter at 11 millimeters. The pathophysiology for diabetic gastroparesis is not yet fully elucidated. Recent research suggests pyloric sphincter dysfunction plays a significant role. When medical treatment like prokinetics fails to treat diabetic gastroparesis, other pathophysiological phenomena should be considered. Endoscopic guided pneumatic dilation has traditionally been used in achalasia to dilate the lower esophageal sphincter. In fact, achalasia is caused by the inability of the LES to relax or stretch. Given that pyloric sphincter dysfunction has been associated with gastroparesis should respond to pneumatic dilation and a reduction in pyloric sphincter pressure. In this case, the clinical response from pneumatic dilation of the pyloric sphincter illustrates the potential of the impedance planimetry system as a therapeutic model for refractory gastroparesis.